There is a mistake being made by the majority of people over 65 who are managing their blood pressure, and it is not the mistake you think it is. It is not skipping medications. It is not eating too much salt. It is not failing to exercise. Those are the mistakes everyone knows about, the ones that get addressed in every blood pressure pamphlet and every routine medical appointment. The mistake I am talking about is more subtle, more pervasive, and more dangerous than any of those because it happens at the moment that is supposed to protect them, at the moment of monitoring itself. At the moment when they sit down with their blood pressure cuff and take the reading that will determine whether they feel reassured or worried, whether they call their doctor or decide everything is fine. Most people performing this measurement in their own homes are performing it incorrectly in ways that systematically and consistently produce readings that are lower than their actual blood pressure or higher than it, or that vary so dramatically from session to session that the numbers are essentially meaningless as a guide to their cardiovascular health. And they do not know this is happening. They trust the numbers. They make decisions based on the numbers. They report the numbers to their physicians who base prescription adjustments on the numbers. And the entire management of their blood pressure, the condition that more than any other determines their risk of heart attack and stroke, is being guided by measurements that are less accurate than they should be for reasons that are entirely correctable once someone explains what those reasons are. This is the conversation that most people never have, not because blood pressure measurement is complicated, but because the specific errors in measurement technique that produce systematically wrong readings are remarkably easy to make and remarkably rarely corrected. And in the context of blood pressure management in older adults, where the margin between adequate control and dangerous elevation is often narrow, and where the cardiovascular consequences of poorly controlled blood pressure are serious and progressive, these measurement errors are not small. Studies comparing home blood pressure readings taken with improper technique to readings taken under controlled conditions with proper technique have found average differences of 8 to 20 millimeters of mercury in systolic blood pressure, which is the upper number. At the individual level, the difference can be much larger. An 8 to 20 millimeter underestimate of blood pressure is a difference that can mean the gap between a reading that prompts medication adjustment and a reading that provides false reassurance that everything is fine. In the context of stroke prevention, which depends on maintaining blood pressure below specific thresholds, this kind of systematic measurement error is not a technical quibble. It is a patient safety issue. This is Dr. Victor Lang, and this channel was built to have the conversations that change outcomes. Hit like and subscribe right now if you want to keep getting information this specific, because the next thing I am going to tell you may change a habit that has been affecting the accuracy of your blood pressure monitoring for years. Let us start with the most common and the most consequential of the measurement errors, because this one alone accounts for a significant proportion of the artificially low readings that give people false reassurance. It is the arm position during measurement. When blood pressure is measured, the reading reflects the hydrostatic pressure at the level of the heart. If the cuff is positioned at a level lower than the heart, the hydrostatic column of blood between the heart and the cuff adds to the pressure reading, producing a reading that is higher than the actual cardiac output pressure. If the cuff is positioned higher than the heart, the opposite occurs and the reading is lower than the actual pressure. Research published in the journal JAMA Internal Medicine, specifically examining the effect of arm position on blood pressure readings, found that measurements taken with the arm resting in the lap, a position that many home monitors are used in because it is simply where the arm falls naturally when sitting in a chair, produced readings that were an average of 5 to 6 millimeters higher in systolic blood pressure and 4 millimeters higher in diastolic pressure compared to readings taken with the arm supported at heart level. Conversely, readings taken with the arm hanging unsupported to the side of the body, another common position in informal home measurement, produced readings that were significantly lower than the true pressure. The arm must be supported at the level of the heart, specifically with the cuff at the same height as the midsternum, the center of the chest, for the reading to reflect actual blood pressure. This means resting the forearm on a table or desk surface of the appropriate height, or using a pillow to elevate the arm on the lap to heart level, not simply resting it naturally wherever it falls. The second measurement error involves the bladder, specifically the size of the cuff's inner bladder relative to the circumference of the arm being measured. Blood pressure cuffs contain an inflatable bladder that compresses the brachial artery during measurement. For this compression to produce an accurate reading, the bladder must be sized appropriately for the arm. If the bladder is too small for the arm circumference, the pressure required to compress the artery through the additional tissue is higher than the actual arterial pressure, and the reading will be falsely elevated. If the bladder is too large, the opposite effect occurs and the reading will be falsely low. Studies on the effect of cuff size on blood pressure measurement have documented errors of up to 10 to 15 millimeters of mercury from using an improperly sized cuff. Most home blood pressure monitors come with a standard adult cuff that fits arms with a circumference of approximately 22 to 32 centimeters. Arms that are outside this range, which includes a significant proportion of older adults, particularly those who carry more adipose tissue in the upper arm, require a large adult or extra-large cuff. Using a standard cuff on an arm that requires a large cuff produces a reading that is consistently and significantly higher than the actual blood pressure, which is exactly the opposite of what people typically assume the error would be. They assume larger means lower measurement. In reality, a too small bladder means the cuff has to inflate to higher pressures to compress the artery, and it records those higher inflation pressures as the systolic pressure. Measuring the arm circumference and ensuring the cuff size is appropriate is a step that most home blood pressure monitor users have never performed and were never told to perform. The third measurement error is the one that produces the most dramatic session-to-session variability in readings, and it is the one most frequently mistaken for genuine blood pressure fluctuation, when the variability is actually a measurement artifact. It is the failure to rest adequately before measuring. Blood pressure is not a static value. It fluctuates continuously in response to physical activity, emotional state, posture change, conversation, eating, caffeine, and the sympathetic nervous system activations that occur in ordinary daily life. The standard medical protocol for blood pressure measurement requires the person to be seated quietly for at least 5 minutes before the measurement is taken, with back supported, legs uncrossed, feet flat on the floor, without talking or interacting with another person during the rest period. This 5-minute rest period allows the sympathetic activation from whatever the person was doing. Before sitting down, walking across the room, having a conversation, ascending stairs, feeling anxious about the reading, to dissipate sufficiently for the reading to reflect the resting blood pressure rather than the activity elevated blood pressure. Research comparing blood pressure measured after the recommended 5 minutes of rest versus immediately after sitting down has consistently found significant differences, with the immediate measurement being substantially higher than the rested measurement, often by 10 to 15 millimeters or more. Most people performing home blood pressure monitoring are measuring within 1 to 2 minutes of sitting down, often immediately after a period of activity, and they are recording readings that reflect not their actual resting blood pressure, but the transient elevation of whatever they were doing or feeling immediately before. The fourth error involves the specific timing within the day and within the context of factors that are known to produce acute blood pressure elevation, including caffeine consumption, exercise, smoking, eating, and emotional stress. Caffeine produces acute blood pressure elevation that peaks approximately 30 to 60 minutes after consumption and returns to baseline over the following 2 to 3 hours. A blood pressure reading taken within 1 hour of coffee is not a reading of the person's managed blood pressure. It is a reading of the person's caffeine-elevated blood pressure, and in someone whose actual resting blood pressure is borderline controlled, the caffeine-added elevation may produce a reading that appears adequately managed when the underlying blood pressure without caffeine might be significantly lower, or the reverse, in which a person whose caffeine raises pressure significantly measures what appears to be uncontrolled blood pressure that is actually adequately managed once the caffeine effect dissipates. The clinical guidance for blood pressure measurement specifies no caffeine for 30 minutes before measurement, which most home monitoring guidance never communicates. Exercise produces sympathetic activation and peripheral vascular changes that affect blood pressure for 30 to 60 minutes after the activity. Measuring blood pressure immediately after a morning walk and recording the elevated post-exercise reading as the management target is one of the most common specific timing errors in home blood pressure monitoring. The fifth error is the one that produces the most distorted picture of blood pressure management over time, and it involves the number of readings taken and how they are recorded. The research on home blood pressure monitoring consistently shows that single readings are highly variable due to all the factors we have discussed and provide less accurate estimates of true blood pressure than the average of multiple readings taken within a session. The recommended protocol for home blood pressure monitoring and guidelines from the American Heart Association and European Society of Hypertension calls for 2 to 3 readings per session, taken 1 to 2 minutes apart, with the average of those readings being recorded rather than the individual readings. Most people take one reading, record it, and use it as their data point. The problem is that blood pressure readings within a single session can vary by 5 to 15 millimeters between the first and subsequent readings, with the first reading typically being higher due to the residual sympathetic activation from positioning and preparing for the measurement. Recording only the first reading, as most people do, consistently produces readings that are higher than the average of multiple readings and that overestimate blood pressure more often than they underestimate it. There is also an error that is less about technique and more about physiology, and it specifically affects older adults in a way that younger adults are rarely affected. It is called white coat hypertension in its clinic-based form and measurement anxiety in its home-based form. The act of measuring blood pressure for a significant proportion of people who are already aware that their blood pressure is being managed triggers an anticipatory anxiety response that activates the sympathetic nervous system and transiently elevates the blood pressure before the measurement even begins. The reading captures not only the person's resting blood pressure, but the added sympathetic elevation of the anxiety about the reading. Research has estimated that this measurement context elevation accounts for an average of 5 to 10 millimeters in systolic pressure in susceptible individuals. For someone whose true resting blood pressure is close to the management target, this measurement context elevation can produce readings that appear to be out of range when the actual blood pressure is adequately controlled, leading to medication dose increases that are unnecessary and that may produce side effects or overcorrection. The clinical solution to this is to take blood pressure at times when the act of measuring has become routine and unremarkable, typically after several weeks of consistent home monitoring, when the novelty and anxiety of measurement have diminished, rather than interpreting the readings taken in the first days of a new monitoring protocol when measurement anxiety is highest. The sixth error involves the device itself, and it is one that most people never consider because the monitor is factory calibrated, and they assume it remains accurate indefinitely. Blood pressure monitors, both the arm cuff and wrist cuff varieties, require periodic validation and calibration to ensure their readings remain accurate. The internal sensors that measure the cuff pressure can drift over time, producing readings that are systematically higher or lower than the actual pressure. The British Hypertension Society and the American Heart Association recommend that home blood pressure monitors be validated against a mercury or aneroid sphygmomanometer, the gold standard devices used in clinical settings at least every 1 to 2 years or whenever there is a reason to question the accuracy of the readings. Most people have never validated their home monitor against a clinical device, and many are using monitors that are several years old or that have been dropped or otherwise subjected to conditions that may have affected their calibration. A simple way to check the accuracy of a home monitor is to bring it to a physician's appointment and take readings simultaneously, or within seconds of each other, to compare the home monitor's reading to the clinic reading. A consistent difference of 5 millimeters or more in systolic reading warrants device replacement or recalibration. Wrist monitors deserve specific mention as a category of device whose use is widespread, but whose accuracy is substantially more vulnerable to technique errors than upper arm monitors. Wrist blood pressure monitors require the wrist to be held at the level of the heart during measurement, which is a positioning requirement that is even more difficult to achieve accurately than the upper arm heart level requirement. Because the wrist is connected to the arm by a joint that moves in multiple planes and that naturally tends to rest at positions other than exact heart level. Studies comparing wrist monitor accuracy to upper arm monitor accuracy in clinical testing consistently find greater variability and greater average error in wrist monitors, and medical guidelines from major cardiology organizations specifically recommend upper arm monitors over wrist monitors for home blood pressure monitoring, particularly in people with arterial stiffness, which is more prevalent in older adults because stiff arteries produce a waveform that wrist-based oscillometric sensors measure less accurately than upper arm sensors do. Now let us talk about what correct blood pressure measurement actually looks like in practice. Because the protocol that produces the most accurate readings is specific, straightforward, and takes only a few minutes more than what most people are currently doing. Sit down in a chair with back support and both feet flat on the floor. Do nothing and say nothing for 5 minutes. Ensure that in the 30 minutes before this session you have not consumed caffeine, exercised significantly, smoked, or eaten a large meal. Position the upper arm cuff at heart level, supported on a table or elevated surface. Ensure the cuff size is appropriate for your arm circumference. Take the first reading. Wait 1 to 2 minutes, remaining seated and quiet. Take the second reading. If the first and second readings differ by more than 5 millimeters, take a third reading. Record the average of the two closest readings. Do this at the same time each day, ideally in the morning before medications and in the evening before dinner, which are the two windows that provide the most clinically informative picture of 24-hour blood pressure management. This is the protocol. It takes 9 to 12 minutes total. It produces measurements that are substantially more accurate and substantially more meaningful than what most people are currently doing. And it is the protocol on which the blood pressure management decisions your physician makes should be based. There is an emotional dimension to this conversation that I want to name before we close. Managing blood pressure is one of the most important things an older adult can do for their cardiovascular health, for their stroke prevention, for the protection of their kidneys and their vision, and their cognitive function that chronically elevated blood pressure erodes over time. The people who monitor their blood pressure at home are doing the right thing. The intention is right. The awareness is right. And the failure of technique that produces inaccurate readings is not a reflection of carelessness. It is a reflection of the fact that nobody ever sat down and explained the specific errors with the specific consequences in language clear enough to actually change the behavior. This video is that sitting down. This is the conversation that should have happened in every physician's office where a home blood pressure monitor was recommended. And the instruction was only, take it twice a day and write it down. The readings you take from today forward can be more accurate. The management decisions that follow from those readings can be more appropriately calibrated. The protection that your blood pressure management is supposed to be providing for your heart and your brain and your kidneys can be more complete. None of that requires anything more than the specific knowledge of how to measure correctly and the willingness to invest 8 additional minutes in the accuracy that makes the measurement worth taking. Tell me in the comments how you currently take your blood pressure readings and whether any of the errors we discussed today were part of your current routine. Tell me whether this changes what you are going to do differently starting tomorrow. And please share this video with every person in your life who is monitoring their blood pressure at home, because the gap between measuring incorrectly and measuring correctly is a gap that has real consequences for real outcomes, and the people you care about deserve to close it. The blood pressure reading that guides your cardiovascular care should reflect your actual blood pressure. Until today, for many people watching this, it has not. Starting now, it can.